afternoon, everybody. Thank you very much, Kidist and Patricia. I'm very happy to be here. I'm really delighted to be part of this great conference. And I'd like to thank the COLDA organizers, the SOLDA leadership, and SLD for asking me to discuss with you, oops, there's no title. Well, risk stratification in portal hypertension. Okay, so I think we heard the word cirrhosis, and we've been told that histological fibrosis assessment is important. However, number one, it's not always available. There is sampling error associated with liver biopsy. There is clearly inter-observer variability at pathology. Cirrhosis may be underestimated if you obtain a short segment or perhaps a tooth in a biopsy, like an 18 gauge. Typically 16 gauge has been deemed more accurate. Complications from different disease occur at different level of fibrosis, like cancer and hepatitis B, for instance, versus autoimmune hepatitis. And finally, as Kidis mentioned, portal hypertension may differ in that portal hypertension may occur earlier in some type of diseases, such as PBC and some FAASLD patients. But there's more. First, medical expenditures are really not related to fibrosis per se, but rather to liver-related event. And I'll use this abbreviation LRE, which actually has been mentioned, I think, at the conference yesterday as well. So basically, decompensating events lumped in this abbreviation LRE. Also, the FDA in the US requires a demonstration of clinical benefit. That means really you have to demonstrate that your molecule leads to less liver-related events for full approval. And case in point, obeticholic acid recently was voluntarily withdrawn by Intercept because of the lack of, or better yet, not a very good benefit-risk ratio. And as you know, semaglutide and resmetirom for MASLD MASH are also under this conditional approval by the FDA. So LREs really matter. And then now we know that the risk of complication, as Kidis has alluded to, are closely related to the level of portal pressure, portal hypertension. Just one word to say that I was interested to see how different people define LREs, and unfortunately it's quite heterogeneous. I put here some random papers from all over the world. Essentially, you see that varies from a very comprehensive list in this Asian paper versus a kind of narrow list from this Canadian Dutch paper. So I'm not going to belabor that too much, just so be aware when you read the paper to know what authors are defining. Talking about definitions, there are two important definitions at this point. I mean, we heard the term cirrhosis. This term, CACLD, I think it's here to stay, has been validated and approved by the SLD guidelines. It's basically compensated advanced chronic liver disease. Essentially, it equals cirrhosis, a clinical way of defining cirrhosis without doing a liver biopsy. For those of you that remember the shock classification, F5 was incomplete or near cirrhosis, F6 full-blown cirrhosis. That's basically what we would, how we would define CACLD. And the other definition that's been around a much longer time is CSPH, so clinically significant portal hypertension. As we mentioned, portal hypertension is the main driver of the decompensating event that is an LRE. Again, this concept of CACLD is basically a clinical working diagnosis for cirrhosis. And why is cirrhosis important? Well, because it should trigger a number of interventions. One of them is screening for HCC, you're familiar with that. But also should lead to specific dietary recommendation in terms of sodium, protein intake, or in case of MASLD, specific dietary recommendation to actually lose weight. It should trigger also some health maintenance recommendation, among others, hepatitis A and B vaccination, as well as nutrition, and also the replacement of fat-soluble vitamins. The fourth, it's a little more recent, to prevent pre-frailty or frailty, again, by dietary intervention and perhaps strength training. To reiterate what Kidis said, normal portal pressure, that's abbreviated PP, is 5 millimeters of mercury or lower. So preclinical portal hypertension would be 6 to 9, and then clinically significant portal hypertension, that's what we're going to focus on today, is 10 millimeters of mercury and above, because that's at the point we start having ascites and a little later on varices. So it is true that the gold standard is still hepatic vein pressure gradient. That's the second line, which is the gold standard because all of the non-invasive tests have been by and large matched to this HVPG as a gold standard. However, one could argue that the direct pressure measurement at invasive gastroenterology by EUS may actually be more accurate sample of true portal pressure, although it may also be argued that it's somewhat more invasive. So the question then is, because these two tests, no matter what, are kind of invasive, are there any non-invasive way to assess or at least estimate portal pressure? Well, there is. I took one model out of many that uses this artificial intelligence assessment. This particular model had 9 variables, and as you see, it had a very good area under the curve, 0.94, to differentiate basically clinically significant portal hypertension versus not. The problem is that there are 9 variables, so it becomes kind of cumbersome, but moreover is requiring to measure spleen stiffness. Spleen stiffness, for instance, I don't do it in my own office with my FibroScan, and also I hear there is significant percentages that actually you cannot get a good reading. So it becomes problematic, and more so in areas where you don't have actually access to a FibroScan. It also requires the presence of very astute radiologists to be able to find shunts or collaterals that could actually be also defining portal hypertension. Other models have been published, including MR or CT, but as you can imagine, these are even less accessible and more expensive than the FibroScan, even in Western economies. So then enters basically the Baveno 7 recommendation. The Baveno, if you don't know, Baveno is a small city in Lake Maggiore in Italy, and portal hypertensive specialists have been meeting there for decades, and they've come out in the latest type 7 recommendation with a simple diagnostic algorithm to diagnose one, in quotes, cirrhosis, which we refer to as COLDA, and clinically significant portal hypertension. What are these 2 variables? Well, one of them is quite easy. Platelets should be available just about everywhere. And the other, liver elastography. Here I have to make a point. The main validation has been with the FibroScan by EchoSense. So not by MRI. And I'll give you an example here that the cutoff for LSM by the EchoSense machine versus MRE are quite different. And the MRE, besides, I'm not sure it's going to gain a lot of traction because of the cost, it's actually quite different, as you can see. So then the Baveno 7 has come out with the rule of 5, and I'm sure most of you are familiar with the rule of 5, but I'm going to go over the next slide. I'll take a little more time. Unfortunately, I don't have a pointer. So the rule of 5 means you use this KPM measurement at elastography in segment of 5. So less than 10, essentially, as you see in the line that says ASLD recommendation. Basically, the recommendation is to exclude cirrhosis. You don't really do anything except the usual, intervention, and repeat this test in 3 years. And then you have by 5 units, increments, 10 to 15, 15 to 20, 20 to 25, etc. And as you can see, it basically matches the estimated fibrosis on the first line as it goes more towards the right. And we can debate whether less than 10 you can actually find hepatitis B patients that may have higher fibrosis than 0 to 1, and that's, I'll readily agree with you. The more important thing is that the LRE, expressed in percentage per year, actually do increase progressively and significantly from segment of 5 to the next segment of 5, as you can see. The other thing that's interesting to see is that this LRE in the obese populations occur later. So basically, if you look at the column 25 to 30, the estimated LRE percentage per year in the obese is similar to non-obese patients at the earlier KPA measurement. And so that means that basically a FibroScan will overestimate the risk in the obese population. And then, as you can see, I think I'm going to go step by step. If a patient has a KPA between 10 and 15, you consider the patient may have cirrhosis, and you look at the platelets to see if the patient should get an upper endoscopy to look for high-risk varices or not. And the 150 is the cutoff there. The next step, 15 to 20, you will assume that the patient has chronic advanced liver disease, so cirrhosis. And then the question is, can you assume now they have portal hypertension? Because if the platelets are less than 110, you would assume so, and that would default, and I think Dr. Jones is going to discuss that, default to NSBB, which are non-selective beta blockers. And then for all these 2 or 3 KPA between 10 and 25, you may want to do a liver stiffness measurement on a yearly basis. So then 10 to 25, you now know that the patient has chronic, basically cirrhosis, and the possibility of CSPH. So the platelets are less than 150, then again, it defaults to use of beta blockers. The last 2 columns, then you don't really need to repeat an LSM. You know the patient is basically at high risk, unless the patient may recompensate, in which case you may want to consider repeating the test. So I hope it's not too complicated. You can take a picture of this. The only thing that I added to the SLD recommendation is the estimate of the LRE per year. Now, something that's important is a change in KPA, and that's why the recommendation is to do it yearly, because a 20% change is deemed to be significant, and it's actually been shown in 2 studies, one Spanish study in hepatitis C patients and another one in MASH patients, that an increase or decrease of liver stiffness will change the prognosis. So if there is an increase, you can expect the compensation rate of about 50% greater than the comparator, so has a risk of 1.5. And a decrease, on the other hand, will translate into decreased liver mortality by as high as 50%, although that changes do not predict extrahepatic death. And another way to look at this, I really would like to give a shout out to Maria Buti's group at University of Barcelona. The Anticipate calculator that's been around, it's very easy to access, completely free. You can, so from the University of Barcelona, we can estimate the chance that the patient has clinically significant portal hypertension, and 2, the % chance that this patient will develop actually one of these events at 3-year follow-up. And so one is called Anticipate, and the other Anticipate NASH, which includes BMI, to factor in what I told you, the difference in terms of liver-related event with obesity. So basically, the conclusions. CACLD is an acceptable and now accepted clinical definition of cirrhosis that should obviate a number of liver biopsies. The risk of LRE in patients with cirrhosis is associated with portal pressure, in fact, clinically significant portal hypertension. And finally, risk stratification is best achieved using a combination of platelets and liver stiffness using the rule of 5, which is expressed in KPA by vibration-controlled transient elastography. Thank you so much.
Thank you.